Hello, everyone. Welcome to thoracic tumors. What I'm going to show you are my personal cases, the best of the best. Thorax is all of mine are CT-guided transthoracic FNA, including lung, pleura, mediastinum. So I use the triple approach: clinical history, radiology, the size of the lesion, the shape, and the texture of the gross material. And then cytology is last. So I use direct smear for stiff quick to measure the nuclear size compared with red blood cell. Background substance for this mucin, glycogen, lipid, lymphoglandular body, metachromatic stroma. And then I use ultrafast PET stain with all the blood has been lysed. I use it to study the nuclear feature and cytoplasm features. And then cell block. All the deep FNA always use a cell block. And cell block, I use it for histology and immunostain. And so here's a first case, 73-year-old woman, incidental corn lesion. And the radiologist say the nodule is mobile to the needle, bounce back and forth. That's a big clue. And then diff quick saying the nuclear size of 1, same as red blood cell. And then on PET saying there are 3 components. This is a composite benign epithelium, chondroid substance, and adipose tissue. So all the ingredients to diagnose hematoma. Here's tissue hematoma. And this is a 49-year-old Chinese woman, PET positive nodule. You see, that's the nodule, very like corn lesion. And the this quick show big nuclear size. Some intranuclear inclusion, and then you tend to, could this be adenocarcinoma? However, in other part of the slide, you have a different component. You have a mesenchymal component. So, this is actual diagnostic. All you need is to do a cell block, and then make sure you order the right immunostain. Cytokeratin, highlight the surface epithelium. PR, progesterone receptor, is positive of the strobel cells. TTF1, say both epithelium and the stroma. So it's a tumor with dual differentiation. It's like diagnostic for sclerosing neurocytoma. And this can, okay. Yeah, here's the thing. So the patient never had a follow-up. And then one day, a colleague told me, Dr. Yan, 6 years ago, diagnosed sclerosing neurocytoma, and it came out finally. She ordered me a REMA, and I think the reason why they took it out because CT shows here's something coming out, but I think it's because the aspiration puncture a hole, this tumor grow out of it. And here's the tumor. It's diagnostic sclerosing pneumocytoma. My point is cells don't lie. It's then the finding, and it's a woman. And the radiologist say it's very resistant to needle when you withdraw because the sclerosing nature of the stroma. So you could tell it's like sticking to the needle. PR, it's a woman, almost benign, divergent differentiation. And here's an ex-smoker with a round nodule, nuclear size 1 to 2x, and ultrafast pepper, beautiful keratinizing cells. This keratin is abnormal because normal keratin, they're translucent. This is thick and refractor. So the keratin is abnormal. It's squamous cell carcinoma keratinizing. And then another 70.
Just click it there.
Okay. 70-year-old man with lymphoma, and surveillance show a PET positive nodule. And so, deep quick, 1 times RBC, but this is abnormal. There's no keratin. It's squamous cell carcinoma keratinizing. And here's a record of that case. A very small non-keratinizing squamous cell carcinoma. And a smoker with a low nodule with smooth surface, CT impression solitary fibrous tumor. And then you have nuclear. How do I stop this? I don't want to use it.
If you go there, it's close to it, it comes up. If you move away, it should go away.
Okay. So this case is very interesting because it had nuclear streak high-density ratio, almost like a small cell carcinoma. However, they're bigger cells, so it's very strange. And so I was thinking at the time, could this be mixed small cell, large cell carcinoma? And then cell block shows, exon 4 immunostate. And it's negative for everything. And positive for cytokeratin. So I signed out as a squamous cell carcinoma with basaloid features. And then here's a recut, lobectomy. Basaloid squamous cell carcinoma. Because this is a pitfall. All these necrotic cells look like small cell carcinoma, but synaptophysin negative, cytokeratin 5/6 positive. So that's a pitfall. And here's a 82-year-old woman with a lobulated right middle lobe mass, abutting mediastinum. And then abundant mucin. A lot of mucinous cells, almost like sickly cells, a lake of mucin. So sign out mucinous adenocarcinoma with sickly green features. And then here's a recut, just a pools of mucin. The thing with mucinous adenocarcinoma of the lung, is part of it is CDX2 positive, but it's not colon. Co-express TTF1 and CDX2. is well known. So finest nuisance adenocarcinoma, blah, blah. It's a stable, large lesion. They saw was an abscess, but it doesn't respond to antibiotics. So finally, they decided to do FNA. Here's a quick 2 times represent numerous cells with almost look like pepper carcinoma, nuclear groups, inclusions, papillary. But even though it's negative for cycloalbumin, positive for surfactant, so it's pulmonary papillary adenocarcinoma. And here's a recap of that case. And this case, elderly woman with a little subpleural ground glass opacity, clinical radiologist impression bronchoalveolar carcinoma, the old-fashioned term. So they aspirate. They aspirate that lesion, and then it shows the cells are much bigger than red blood cell, 3 times, so it's malignant. And then it has an inclusion. So I signed it out as a well-differentiated adenocarcinoma with bronchoalveolar features. However, they did the basal segmental tummy, and there's no lesion, nothing, no malignancy identified. So, but I truly believe cells don't lie. I think the surgeon took the wrong segment. So I keep following this because I truly believe cells don't lie. So I waited 5 years later. Finally, they did the wedge resection. You see, my point, cells don't lie. If it's the sampling, maybe the surgeon didn't pick the right spot.
So, Grace, was it the same institution and same surgeon who followed this up 5 years later, or
yeah, same. Yeah, it's a little lesion, you know. My point is trust cells.
Yes.
If there's discrepancy, maybe there's so many factors. Don't like all of a sudden scared of cells. I get killed by the cells, you know. And that's why I want to show this case. Cells don't lie.
They don't. And actually, in the last 8 weeks, I have had 2 cases exactly like that.
Yeah.
And minimal sample.
Yeah.
Cells, but yeah. We made a call.
Yeah. Exactly. That's why. That's. And you know, when you sample here, it's correlated with cytopathology very well. And then 50 this is a NYU case. 58-year-old man, smoker, a huge lung mass, adrenal mass. So the quick shows some big nuclei, and then ultrafast PAP shows a lot of spindle cells. And then cytokine positive. So it's spindle cell giant cell carcinoma. And then smoker with low mass, and then adrenal mass, numerous giant cells. Giant cell carcinoma. And so the fellow and I wrote this up ages ago when you were babies. 70 elderly woman, a huge 15 centimeter long mass, but no mass. Okay. And I saw the gigantic cells and cell blood. The only thing positive is Vivancin. So I just signed a sarcoma. And then I diligently do tissue follow-up was squamous cell carcinoma. I said, how come? Because the sample for FNA is the sarcoma that's near the pore. And then the squamous cell differentiation is near the bronchus. And my point is, when you have an elephant, you sample the nose or sample the tail. It's so different. So size matters. So the cells did not lie to me. It's so huge. So sarcomatoid carcinoma, when you have, I show you pure spinal cell, pure giant cell. But if you have squamous cell carcinoma, adenocarcinoma, we call it pleomorphic carcinoma. The thing is, spinal giant cell components more than 10%. Also, you could have carcinosarcoma if sarcoma components are to differentiate from rhabdochondral osteosarcoma, carcinosarcoma. How to distinguish small blue cells on cytology smear? You're not allowed to do any, no cell block, just cytology. Stiff quick.
Look at the background.
You see, just look at the stiff quick small blue cells. There's no lymphoglandular body. There's no lymphoid tangle. The cells are very rigid, like sesame seeds. Because the carcinoma will different neuroendocrine tumor. The cell biologists say nuclear lemon ABC are intact, so cells are not crushed by smear. And lymphocytes have lymphoid tangles because nuclear lemon A and C missing. That's why you have lymphoid tangles. Small cell carcinoma, nuclear lemon A and C missing. Therefore, you have nuclear streaking in cytology. So the cell biologists love to collaborate with cytopathology, see which crew works, then they're going to analyze because they're going to find some difference. So in this case, how to tell small cell carcinoma from lymphoma? Because small cell carcinoma have nuclear peptidic nuclei. Lymphoma has lymphoglandular bodies. Those are viable cytoplasmic fragments. And so small cell carcinoma nuclear molding, it's because what I just said, the oncogene unique for small cell carcinoma. And here's a case, there's no nuclear streaking, small blue cell with salt and pepper chromatin. So it's well differentiated neuroendocrine tumor, depending where it comes from, has different name. this case is carcinoma. And I had a case at Bellevue, 50-year with a big lung mass. So there's a lot of neutrophils and typical salt and pepper chromatin. And mid-1 was pretty increased. So atypical carcinoma, here's the lumpectomy of that particular case. You see microabscesses. Here's a small lung nodule. And the patient recently diagnosed another lung cancer. And then I see big nuclei. And synaptophysin positive. So it's not a large cell neuroendocrine carcinoma because a patient have a choice which one should be excised first. So they decided to take this one out first because this is more aggressive. Here's histology, lobectomy. See, look at it, large cell neuroendocrine carcinoma. All I have in this case. And then this is very interesting case, Egyptian lady, abnormal chest X-ray before polypectomy. CT scan shows 3 nodules, right upper middle lung, and then nearly 10 sub-centimeter by the nodule, while metastatic disease. And then some spindle cells, and then some collagen, metachromatic stroma, collagen. And the cell block is really weird. I said, what is this? Papillary something I want to show to everybody. The G1, a big differential. And then I even consult, and I did cytokeratin 7 positive of the lining cells, PDF. And I also consult with Dr. Jagada, who was my thoracic attendant at NYU, and she suggests me to do beta-catenin. And then she said it's pulmonary well-differentiated fetal adenocarcinoma. So they took it out, just took it out. Here's the wedge resection. All 3 look like this. Isn't this weird? With the airspace, a lot of papilla. And then it was called pulmonary carcinoid tumor. Background patchy neuroendocrine hyperplasia. And then actually this rare tumor was described in 1981 in cancer. They say typically have airspace. So I wrote a paper to show this case, a rare morphological variant. And then, so this is carcinoid. It goes to totally different pathway from high-grade neuroendocrine carcinoma. A different kind of expression, everything from hyperplasia to tumor to carcinoid. Then, and from tobacco, you have high-grade neuroendocrine carcinoma. It's 2 different animals. Here's a 61-year-old with a lung mass. What is this? It's spindle cell mesenchymal tumor. Low grade. So it's a Bellevue case. So they took it out. It's a giant tumor, 32 centimeter, pro-based tumor, compressing level, solid fibrous tumor. It's benign. Just Bellevue have all kinds of weird case because a lot of the people, they don't have money. They wait until immigrant, in teaching hospital, you have this little nothing, and patients scared to death. And then at Bellevue Hospital, they just keep on working. They can. That's why you have those exact cases. Park Avenue patient, pleural mass compressed with pleural effusion, a woman. And she was a buyer for clothing with no exposure to espresso, never smoked, Park Avenue case. So you have this tumor cell, epithelial tumor cell. Kind of weird, like this configuration. But the cells really look like mesothelial cells. So carotid EMA highlight the very long microsurface villi. So malignant mesothelioma. Patient was treated at Mount Sinai Hospital. This is second cases of FNA mesothelioma. And then this is effusion. You see, the cells of mesothelioma versus benign mesothelial cell hyperplasia, adenocarcinoma. Only mesothelioma have this long microvilli. You see, that's cytology. Long microvilli. And here's a FNA mediastinum mass. Here, mediastinum, you have anterior, middle, and posterior. Here's the anatomy. So in posterior mediastinum, you have spinal nerve, ganglia. So in posterior mediastinum, you have neurogenic tumors. And then in anterior middle, so it's very important to know where it came from. Seminoma. So you could have those fancy tumors, ganglioneuroma, paraganglioma. Here's a young woman with a huge posterior mediastinal mass. Here is an NYU case. Those tumor cells were definitely very diseased. And then you have interconnecting cell processes. And it's a clue for paraganglioma. And that's how it's signed out at the NYU. Here's a record of the tumor. So you look exactly like cytology. Because the beauty of cytology smears, once you smear, you could see the cell to cell in connection, cell junction. You have tissue preference section, you just cut it. You never have a chance to test the cell to cell junction. Cytology. here's a young woman with posterior sinus mass. You see all these things, and then little dots are pop up. Something pop out, like ganglion pop out. This is a case I had at Cornell, 1992 or 93. Yes, ganglion. Those are stroma, ganglion. So it's a nice example of ganglion neuroma. Same thing. The beauty of cytology is you could have fun guessing what this could be and anxiously wait for several for tissue follow-up. This is 23-year-old posterior sinus mass. 2 weeks ago, they took it out. There's a tumor. And then she developed liver metastasis. You have this like tadpole-shaped cells with a lot of melanin. So like myeloma, but she had a resection of Seminoma. So it's the melanocytic component that maps to liver. That's the recap for the surgical pathology. In surgical pathology, the doctor to pay attention to this melanocytic. So that's all posterior medial sinus. Anterior medial sinus, you could have a lot of lymphocytes and then spindle cells, all this epithelium. A classic for thymoma. Here, a Bellevue case, emergency, because this 52-year-old woman has superior vena cava syndrome. FNA is so emergent. The FNA shows different, shows cells like this and some lymphocytes. It's really weird. It cannot be a Seminoma because it's a medical emergency. A due population of large cells and lymphocytes. Cell block, all those big cells are LCA positive. So it's really interesting. It's quick. So it's
You can go back by using that. Okay.
It's okay.
It's a T-cell lymphoma?
It's T-cell lymphoma. It blocked it. Yeah. Okay. PI cytotoxic large T-cell lymphoma of the mediastinum. It's really weird. That's why I want to share with you. Bellevue case.
I thought of a tiny carcinoma or something.
Yeah, that's why clinical follow-up respond very well to CHOP and radiation. 6 months later, there's no evidence of disease. It's very aggressive, but they respond very well to chemo. That's why it just is so weird. I want to share with anterior sinus mass. in a woman with the FNA cervical lymph node have those big cells clearly malignant. And so many malignant cells is too much for Hodgkin's lymphoma. And shows all those big cells are B cells. So it's a B cell lymphoma. And mediastinal tissue biopsy shows this. So it's an example of primary mediastinal large B cell lymphoma. So the last category is germ cell tumors. Seminoma, adenocarcinoma, yolk sac tumor. Here's a classic textbook case. You have thyroid background because the glycogen droplet, all those are glycogen. Tumor cells with macronuclear lymphocytic background. Positive. It's straight, it's very easy presentation. And then, so that's typical seminoma. And then I have a Bellevue patient, young man, Chinese, completely progressive short of breath. So, no wonder you're short of breath. This big tumor, typical Bellevue patient. So FNA was performed. Then you have tumor cells and neutrophils. But the cells here, cell to cell, it seems connected. So this part is not lymphoid. This could be lymphoid. This could not be lymphoid. But then it is the on cell block PAP negative, cytopathology positive. And so it was inconclusive. They did a frozen section. I just said malignancy uncertain type. So they did a frozen section. Here's a frozen section. In this case, PAP negative, HCG positive, cytokine bat-like. So it was signed out as atypical seminoma. Clinical follow-up. Respond to cisplatin etoposide type, live and well, and now disease free. So it's a happy story. Now he can breathe. Yeah. And then Cornell, 1994, had a really weird case. It has this substance, really weird. And I sent it to Dr. Tao in Indiana. He told me he has seen this before. So he told me a clue. It's this substance. It's yolk sac tumor. It's hyaline globules. See? So that's 1994. And then later at Bellevue Hospital, I saw a similar case. Smoker, woman, lung mass, and mediastinal mass. Clinical impression was who are lung cancer with hyaline mass. And then I saw the same substance. So I told the clinician to do to check alpha fetal protein. Hyaline globules, same thing. And they thought I was crazy, but they did the serum alpha fetoprotein. You see, after treatment, broke down. And then a few months later, the residual tumor, they took it off. And then the confirmed yolk sac tumor. Dr. Jagan said, how do you know it's yolk sac tumor on cytology? It's because I grew. But the patient still died from brain metastasis. My whole point is cells don't lie. Okay, that's my point. And here's a 38-year-old with testicular cancer. And his tumor cells with big nuclei. This is an example of multiple nuclei. Embryonal carcinoma exam on cytology. So we share our experience. And so what I showed to you are from hematoma all the way down to mediastinum FNA. Just the most interesting cases I encounter, I'd like to share with you. And here's the book. Okay, that's it. Did you have any questions?
Go ahead.
Yeah.
It's amazing. You can click on that. Double click.